I'd like to discuss with you one of our patients. Do you have time?
Of course, yes. Go ahead, please.
Well, this is a patient actually referred to me by the surgical team. He did a colon surgery about 2 weeks back, and actually he had a history of 2-month bleeding per rectum. They did for him a surgery, and actually they are asking me because the pathology report is now released.
Okay, yes, perfect. So
well, I'm going to read for you the pathology report. Well, it's showing a T2 poorly differentiated adenocarcinoma with positive lymphovascular invasion and negative perineural invasion, and there were 7 lymph nodes removed, all are negative, so it's an N naught, and it was an R0 resection as well. So they're asking me whether we need to give him an adjuvant chemotherapy or not.
While this patient has less than 12 lymph nodes sampled, also positive lymphocyte invasion, and harbors poorly differentiated histology, which are all adverse prognostic features, he has a stage 1 disease. Chemotherapy adjuvantly is not indicated for patients with stage 1 colorectal cancer. If this patient had stage 2 colon cancer with high risk features, he could be offered adjuvant chemotherapy in the form of 5-FU or capecitabine single agents. For stage 3 colorectal cancer, doublet chemotherapy would be indicated.
Dr. Asad, a 55-year-old male patient was referred to you for discussion on adjuvant chemotherapy for a resected colon cancer. What marker are you looking for to decide on his treatment?
Well, let me think about it. If I may, I would like to ask about the staging and MMR. I think if it is Dukes B.
You think?
Yeah, most likely I will ask for the MMR and the staging.
Well, he has stage 3. However, the patient is a research scientist, and he went for a molecular testing privately, which revealed he has a mutation in the BIK3CA gene. What other treatments you can advise him on?
Well, BI3K.
Preclinical data shows that inhibition of cyclooxygenase 2 by aspirin downregulates PI3K signaling pathway. In a published report of more than 900 patients with colorectal cancer, regular use of aspirin after diagnosis was associated with a longer survival among patients with mutation in PIK3CA genes, but not among patients with wild type. The findings from this study suggest that the PIK3CA mutation in colorectal cancer may serve as a predictive molecular biomarker for adjuvant aspirin. However, prospective data is needed on aspirin and COX-2 inhibition in patients with colorectal cancer with PIK3CA mutations before integration of this mutation with other currently used predictive biomarkers in this disease.
Dr. Hassan, can I ask you a question about one patient?
Yes, of course.
Mrs. Sarah is a 59-year-old lady with adenocarcinoma of the left colon, and she has also liver and lung metastasis. She has multiple comorbidities. She has hypertension, she has chronic renal failure, she had an old CVA about 5 years back, and there is no residual neurology. Her eGFR is actually 25, and her bilirubin is 65 unit millimole per liter. She was admitted with severe abdominal pain, which is more likely related to her cancer. And apart from that, she's in a very good shape with a performance ECOG of 1.
Okay, so have you discussed with the gastro team to see if there are any options for the high bilirubin?
Well, indeed, they think it's hepatocellular related to the malignancy, and the stenting is unlikely to help.
I see. So do you have the molecular studies then?
Yes, she's KRAS and NRAS wild type. The tumor is microsatellite stable, and the PRAF is wild type as well.
For this patient, bevacizumab should not be given in view of the history of TIAs. Irinotecan-based therapy is contraindicated as well, as the conjugated bilirubin is more than 3 times the upper limit, and a stent cannot be performed to lower her bilirubin. Capecitabine is also contraindicated for patients with creatine clearance less than 30 mL per minute. Oxaliplatin can be given to this patient. However, a dose reduction should be performed giving her creatine clearance. For this patient, FOLFOX plus panitumumab would be the best option. Of note, the PRIME study showed high effectiveness of this regimen in patients who were wild type on the extended RAS testing. As the tumor originated in the left colon, this predicts a significant benefit with the anti-EGFR therapy.
We are going to discuss Mr. Ali now. He's a 78-year-old male patient, and he's currently in our ward. And he presented with weight loss and tiredness. He denied any bleeding per rectum. He denied nausea and vomiting. And we did for him tumor markers, and it showed that the CA19 was high at 6,890. The CEA was 7. And the PSA was 0.23, so both were normal. The calcium was raised at 3.45, and we actually staged him. We did a CT scan, and the CT showed bilobar liver lesions as well as bone lesions involving many vertebrae and ribs. There were no other suspicious lesion, and the picture was consistent with the disseminated malignancy, but there was no obvious primary. We did the liver biopsy, and I hope the histopathology can give us a clue about the diagnosis.
Right. The liver biopsy confirmed a poorly differentiated adenocarcinoma. It was diffusely positive for CK7, CK20, CK19, and CDX2, negative for chromogranin and CK5. The immunophenotype is not specific for anything, unfortunately.
I think we need somebody clever to tell us where to go from here. Where is the oncologist?
Colorectal cancer is the most common primary site in patients with liver metastases. Bleeding per rectum is one of the most common early signs of colorectal cancer, but this sign can be absent in some patients. While performing endoscopies would be appropriate, the priority would be given for the lower one to investigate a possible colorectal pathology.
We hope you liked our video. This is Acting for Clinical Education.
And don't forget to check the reference down below.
Please like, share and subscribe, and don't forget to join us every Thursday 5 p.m. Greenwich time.